So I'm really excited to present this work. This is going to change gears a little bit in terms of the themes. So I'm an infectious disease modeler, and I did my PhD in a lab that focuses even before COVID-19 on emerging infectious diseases. And so when the first outbreak started to occur in Wuhan, I was immediately thinking about this in the context of this broader problem, which is that there is this vast diversity of zoonoses, viruses that can spill over from animals into humans, and some of those have potential to cause pandemics. This is a figure from a paper put out by the folks at the EcoHealth Alliance showing that there may even be thousands of these zoonoses that are not even yet known to science. And so I guess there's no way to prove this for sure, but the way that we often think about spillover is that spillover is probably happening quite regularly, but what's rare is that one of these zoonoses gets into a human and actually has the potential to spread in a sustained way from person to person and gains the ability to cause a large outbreak. And so kind of the million-dollar question is, as we do new viral discovery and survey these reservoirs, the million-dollar question is trying to figure out which one of these viruses actually poses a risk of causing the next pandemic. And I think despite a lot of important research that's going on in this area, we still unfortunately live in a world where one of the best indications we have that a particular pathogen has the potential to cause a larger outbreak is that it has already started to cause an outbreak that we have detected. And so as epidemiologists and researchers, this puts us into a position where when we first detect these outbreaks, we switch into this sort of response mode where the challenges that we face are much different than the challenges that we would normally face in sort of peacetime research. So the idea is that we need to figure out very quickly if a pathogen actually has the potential to spread in a sustained way from human to human, or if this is just some sort of repeated introduction case where the outbreak should be self-limiting and not spread any further, even if we don't intervene. And of course, time is of the essence here because we often have to intervene very early and very aggressively to contain a potential pandemic outbreak. But on the other hand, we know there are these really high social and economic costs for a false alarm. To make this even more challenging, we're often doing these analyses using data that is incomplete, biased, and that we know is often changing in real time as we figure out how to study this new pathogen. And so kind of the broad theme of this talk is that ideally, this is not an appropriate moment for modelers and analysts to be learning and developing new methods on the fly to deal with these issues in the data. I do think that one of the big takeaways from COVID-19 is that we really need to invest better in surveillance so that we have better data available to inform these models. But even with better data collection in place, we should always expect data on emerging infectious diseases to be lagged and incomplete. And we as sort of statisticians should be thinking in advance about these problems and trying to design methods that are ready to pull off the shelf and deal with them. So I'm going to focus specifically today on this statistic, the reproductive number, which I'm sure you're all familiar with at this point in the pandemic. The reproductive number is defined as the expected number of new infections that a single infected individual will cause. And it is this metric that we use to assess early in an outbreak whether a pathogen has potential for sustained human-to-human transmission, given that the reproductive number is greater than 1, meaning that on average, each infection is more than replacing itself. And then during an outbreak, we can use the time-varying effective reproductive number, which accounts for things like changes over time in population susceptibility and public health interventions, to monitor how the outbreak is going and to figure out if our public health interventions have been effective. And so I'm going to use this as sort of a framework to highlight some of the ways in which we were not really prepared to deal with challenges in the underlying data early in the COVID-19 pandemic, and ways in which I hope that we'll be better prepared to respond to the next outbreak. Okay, so I'm going to focus on this version of the reproductive number, which we call the time varying effective reproductive number. And this is a version of the reproductive number that we estimate empirically. So ideally, if we could observe every single transmission event in the pandemic, we could just go into the data and we could count the number of new infections that each infected individual is causing. We could take the average at a particular point in time, and that would give us our statistic. So this isn't just some theoretical quantity that exists in a model. Of course, we can't really observe most transmission events. So in practice, what we do to estimate the statistic is we take two key forms of data. So the first thing we need is a time series that gives us counts of the number of new infections that are occurring at a particular point in time. And so that forms the numerator of this equation. And in the diagram, it's represented by the blue downward arrow. So we want to take the number of people that are becoming infected on day T, and we want to divide them by the number of people who are currently shedding virus, given that they appeared in our data set at various points in the past. So using that time series, we can count up the number of people that became infected at all points previously, and then we scale their current infectiousness based on how long ago they themselves became infected. And we do this scaling using something called the generation interval distribution, which is a probability distribution that we usually estimate from contact tracing data where we have observed chains of transmission. And this distribution tells us something about how long we should expect to wait between the moment that person A and person B appear in our data, given that person A caused infection in person B. Okay, so the two main ingredients in our estimation are this generation interval and a time series of the number of case counts. And I'll start by talking about sort of the challenges that we faced in producing these estimates to guide real-time pandemic response back when policymakers in Illinois were trying to ask us to analyze their data and help them figure out how their interventions were working. And so I'm going to start with this figure as sort of a cautionary tale of the traps that you could fall into using the methods that were available prior to COVID-19. So this is a figure from a paper that was published back in April of 2020, very early in the pandemic. And what this paper did was they took a time series of confirmed case counts from Wuhan, and they just fed it into this R package that had existed for years and was designed to input these count data and output these estimates of the time varying reproductive number with credible intervals. And so then the authors overlaid this with these notes on which kinds of interventions had been adopted in Wuhan at different points in time. And the clear goal here is to infer sort of what level of intervention was necessary to make the reproductive number start falling. And then eventually, what level of intervention was sufficient to drive the reproductive number below this threshold of 1, where once we fall below this threshold, the epidemic has started to shrink. Okay, so the first thing that I want to draw your attention to here is the suspiciously narrow confidence intervals, especially given how early in the pandemic these estimates were produced and how much sort of general lack of knowledge there was about this pathogen and case ascertainment. And then the other thing that I want to point out here is the crucial importance of accurately being able to infer when the reproductive number starts to fall and when it crosses 1 in this analysis. So the time scale of this whole x-axis is pretty small. It's just barely over 2 months. And so if we're inferring the timing of this RT crossing 1 inaccurately by just as little as 5 days or a week, we can infer something qualitatively different about what level of interventions are necessary and sufficient to bring about the outcomes that we want from this analysis. And that's a problem because it is entirely possible to be off by weeks if you're not extremely careful with how you adjust the data that you feed into these methods due to lags to case observation. So essentially the problem is that when we're trying to estimate the reproductive number, what we're concerned with is something about the number of new transmission events that are occurring at different points in time. But like I said before, we don't observe these transmission events. Instead, what we observe are these things that occur days or weeks later when people show up for outpatient testing or end up in the hospital. And so if we take one of these observed time series, but we don't sort of shift them backwards to reflect the actual dates that those people became infected, we could get an answer back from these methods that existed prior to the pandemic, but those answers that the computer was spitting out were not necessarily going to be oriented to the correct calendar dates. So we can think about this as sort of a shift on the x-axis in the answers that we were getting back. And so it actually turns out that once we dug a little bit deeper, it's more challenging to deal with these delays to observation than just shifting back in time. And so we can sort of visualize the issues that we're dealing with using the synthetic data. So the curves in this figure represent a simulated epidemic that I generated using an SEIR model in which the underlying transmission rate falls, simulating an intervention at this time point where there's this little bump in the curve. And so here, the yellow curves represent the number of new infections that are occurring each day as though we could observe them at the moment transmission is occurring. So the yellow curves here are sort of like the ideal data that we wish we could observe in practice. And then the green curves represent something a little bit closer to what we can actually observe, accounting for realistic delays to case observation or realistic delays to death for SARS-CoV-2. And the point that I want to emphasize here is that accounting for these delays shows that not only are our observations, not only are the green curves shifted into the future relative to the unobserved truth, but these green curves are also blurred. That is, peaks and valleys in this time series that we observe are sort of smushed relative to the true underlying changes in transmission. And that's a problem because when we're estimating the reproductive number, as I said when I presented that equation, fundamentally what we're interested in is something about the ratio of the number of infections that are occurring at different points in time. And so this blurring can qualitatively and quantitatively affect our estimates if we don't try to remove it. And so, the intuitive thing to do to try to make these adjustments is to just take the green observations and try to shift them back on the x-axis by whatever we think the mean delay might be. That's represented in the blue curves here. Or you might try to subtract individual delay times from each individual observation in this green curve, and that's represented in pink. And you can see that those strategies can temporally recenter the observations, but they either fail to remove this blurring, or in some cases, they even make the blurring worse. And so in order to adjust for delays to observation best, we want to use this class of methods called deconvolution. And I'm not going to go really into the details here, but basically deconvolution is this class of methods that was originally developed in the context of signal and image processing and is now sort of being increasingly applied to epidemiological data to try to deal with these issues of lagged observations. Deconvolution essentially treats trying to recover this unobserved yellow time series of infection events. It treats this as a formal likelihood-based inference problem rather than just trying to do some sort of transformation to the data that we observe. And so you can see in the red curves here that applying these methods to our observations can do a better job of recovering something closer to the truth, which in turn will improve the accuracy of our reproductive number estimates. But I'll pause here and just kind of come back to this main point that I emphasized at the beginning, which is that ideally our analytical tools, our software would be designed to do these kinds of adjustments automatically, because in the moment when we were trying to respond to the outbreak in real time, it was not obvious that this deconvolution approach would be the best practice to adjust for these delays. And then once we sort of determined what best practices were, it also takes time to figure out how best to implement this and kind of incorporate uncertainty from the adjustment into the estimates that we were producing. And I think the importance of thinking through how to deal with these issues in the data becomes even more apparent if we acknowledge that these lags are not the only problem that we were trying to deal with. So in this figure, you can see the gray bars represent our observations. The green curve represents this sort of unlagged estimated time series of infection events after trying to remove the lags. But these estimated infections also are adjusting for things like these weekly fluctuations in reporting, either through some sort of smoothing approach or through an explicit time series-based adjustment. We also have to account for the fact that policymakers are often most interested in recent changes in how the epidemic is progressing. And yet we know that the most recent infections have not all been observed at the time we're doing our analysis. And so it's quite important, I think, to use statistical methods that account for that kind of missing data and uncertainty and return confidence intervals that clearly communicate to people who are making decisions that we may not be as confident as we'd like to be that, say, the reproductive number has fallen below 1, indicating that we're doing well, or that it's risen back above 1, indicating that we might want to tighten interventions. And so I want to highlight this work by my colleague Sam at the London School of Hygiene and Tropical Medicine. Sam works in Sebastian Funk's group, and he's been leading development of this new R package called EpiNow2, which is really nice because it incorporates all these different kinds of adjustments to the data within a single Bayesian model. And this provides a bunch of advantages. First of all, this is basically the kind of plug and play solution that I was advocating for at the beginning. So we can just hand the data to this analytical tool and it will do all these adjustments basically automatically for us, and it'll spit back out an RT estimate that has much wider confidence intervals around it than what I originally presented. And this is also nice because while this single model is doing all these adjustments, it's also incorporating all of the uncertainty from those adjustments in the same place. And so the error that, or the uncertainty that we output is much more realistic than in the original methods that I showed. Okay, so I'm not going to spend too long on this, but I also want to emphasize this other issue of using the reproductive number as a tool early in the outbreak. And so I'll start this sort of section by just framing that early in the SARS-CoV-2 pandemic, reproductive number estimates ranged all the way from 1.5, which is low enough that it's just barely above the threshold where we think that this pathogen can have self-sustaining transmission in humans, all the way up to 7, which indicates that this pathogen is spreading quite quickly and quite efficiently, and that we need to act very aggressively to try to contain it. So this is essentially not a useful range of variability to support decisive decision-making. And I'd argue that if we could have been more accurate, if there had been more consensus in these estimates, it might have been easier to respond faster than we did. And so one of the main sources of uncertainty in those early reproductive number estimates, I'd argue, came from the fact that we didn't really know what the generation interval was for this pathogen. So we said before that the generation interval is this one of the 2 crucial ingredients that we need to estimate the reproductive number, and it tells us something about how long we have to wait between consecutive transmission events in an epidemiologically linked chain. And so the figure in this slide is another simulation study that shows how sensitive our reproductive number estimates are to misspecification of the generation interval. So in this figure, the black line represents the true underlying reproductive number value in a simulation. And we set this value so that it would initially start off somewhere in the range that we thought SARS-CoV-2's reproductive number might be, then it would drop, simulating some sort of intervention, and then it would rise again when that intervention relaxed. And so the colored lines and ribbons in this figure represent our estimates of that reproductive number, assuming that we plug in different assumptions about what the generation interval is to the methods that I described earlier. And so the point here is that if we know exactly what the generation interval is, if we plug in the correct value, which in this case is 8, represented in the green line, our estimates are dead on. But if we get the generation interval wrong, then our estimates are systematically biased. So we're either dramatically overestimating or dramatically underestimating what this pathogen's reproductive number actually is. And the magnitude of these biases, inconveniently, is greatest right at the beginning of the outbreak when the reproductive number is substantially greater than 1. And so this is this crucial time for decision making at which we are least likely to actually know what the pathogen's generation interval is. And as I said at the beginning of this slide, I think this really contributed to uncertainty and hampered decision making. And so there have been many people in the field, including a lot of conversation on Twitter early in the pandemic, that suggested maybe we should be using alternate transmission metrics early in an outbreak, such as the exponential growth rate or the epidemic doubling time. And the argument for using these metrics is that they do not depend at all on knowledge of the generation interval. We can produce these estimates just using that other ingredient in the reproductive number, which is a time series of counts. And I think the main reason that people in our field didn't move toward this estimate is just that we are trained to think in terms of the reproductive number. And so it's harder for us to interpret these alternate metrics. It's kind of like being raised in a country that uses Fahrenheit to measure temperature and then suddenly going to somewhere that uses Celsius, and you have to think really hard to make sense of what you're getting back. But I think this is a surmountable problem, and I think this is an important conversation that we should be having so that we're more prepared to analyze and interpret data the next time we have to respond to an outbreak. Okay, so just wrapping this up, models are only as good as the data that informs them, and I do think that this pandemic has highlighted this really urgent need to develop better surveillance infrastructure and data sharing so that we can figure out what's going on early in an outbreak and hopefully contain it before it spreads to become a pandemic. But even if we do that, even if we build better data collection infrastructure, we should still expect there to be imperfections in the data, such as lags to observation, missingness, and bias. And to the extent possible, we should be trying to design analytical tools that are robust to those predictable problems. And then I also want to highlight that it might be necessary to also rethink what kind of methods and statistics we use to do this kind of outbreak assessment early on so that we're producing estimates that are most robust to the kind of minimal availability of information that we should expect early in an outbreak. So with that, I'll just thank all of my co-authors. Most of what I talked about is summarized in this paper, which kind of came together organically as we and a bunch of other people were scrambling to try to produce estimates accurately. And I especially want to thank my advisor at UChicago, Sarah Kobe.
Thank you very much, Katelyn. Very interesting. And we're open for questions now. I have a couple just to start off. The R values that I believe are published online by Johns Hopkins and the New York Times, where do those come from? What do they represent? What are they telling us?
So that's actually a good question. I haven't looked specifically at the methods that they use, but it seems like what most people are converging on is this sort of like Bayesian smoothing model, which is similar to what is used in those packages. And so the idea there is that you're sort of fitting an epidemic model to case counts. And then through that model, using assumptions about the generation interval, you're extracting these RT estimates. And I do think that those methods can be quite robust if they include these sorts of adjustments for lags, and if they approach this sort of smoothing and bumpiness in the data issue appropriately. But I do think that most people have kind of gotten up to speed on this at this point.
You may have mentioned this, but can you go back now and look at the data, the actual data from earlier in the pandemic, and recalculate the R values and see how accurate they were in terms of what was being provided to the public?
Yeah, so there's actually a paper that does this, and it definitely shows that like there is a clear relationship between early estimates and what people were making or what people were assuming the generation interval was. But then there's also sort of a relationship to uncertainty or like trends in reporting in the underlying time series, right? Because both those ingredients can affect the quality of your estimates. And so I do think that the true value is probably somewhere in the middle of the range that we were seeing, but I think that using statistics that are a little bit more robust could have gotten us like a much narrower range early on so that we could be more confident in what we were dealing with.
And a question from one of the panelists, Jim Bussell, asked, you gave a very interesting and challenging talk. If you had known all of this in September of 2019, how might that have changed the pandemic?
Yeah, I mean, I will definitely admit that there was a period of months, not weeks, where we were trying to figure out how to do this well and just trying to get the data that we needed in hand to do these analyses. And that was surprising to me. I mean, I definitely thought when we started working on this in like February or March that within a week or two we would be rolling, but that wasn't the case. And there are modeling studies that suggest that if we had adopted shelter in place just 1 or 2 weeks earlier and then sustained those interventions, that tens to hundreds of thousands of illnesses and deaths could have been prevented. So yeah, and I think that countries like Australia, New Zealand, Hong Kong that have managed the pandemic well really illustrate that maybe that could have been true. And so I do hope that we put better systems into place so that we're more prepared in the future.